Great. Thanks for coming out this morning and allowing me to present one of these plenaries. I'm looking forward to the discussion all morning, and hopefully many of you can join us. So thanks again, and it's great to be here. I think the last one of these I went to was probably maybe almost 8 years ago or 9 years ago, so it's been a while. First, I'm a medical doctor, so I got to start with my conflicts of interest. I have just a few. Suffice it to say, I've started a couple companies. I consult for a bunch of companies. I wouldn't blame you if you didn't believe another word I said over the next 20 minutes or so. All right, so let me start by introducing or reintroducing the University of California to you. So a lot of people know UCLA, a lot of people know UC Berkeley, but the University of California is an incredible enterprise if you think about it this way. We have 10 campuses and 3 national labs. For example, we have 3 supercomputer centers, Lawrence Berkeley, Lawrence Livermore, and San Diego supercomputer centers. We have 200,000 employees. That actually makes us one of the larger employers in the United States, 250,000 students a year. And now we've created a construct that brings all the medical schools and the other health professional schools together under one umbrella called UC Health. And that's what I'm really going to be spending most of my time explaining. We have 6 medical schools. That's UCLA, UCSF, Irvine, Davis, San Diego, and Riverside, plus 12 other health professional schools, so dental schools, veterinary, nursing. We train half the medical students and residents in California, so if we actually teach them something useful, they can carry that forward into practice. And then the rest are just numbers, $2 billion in NIH funding, 12 plus billion clinical operating revenue, so it makes us one of the larger agglomerations in the United States. We have 5,000 physicians on payroll, but 100,000 doctors write orders on our patients or prescriptions, 12,000 nurses, and we're not just a random set. UCLA and UCSF certainly are in the top 10. We only mention those things when we're in the top 10. Of course, we don't care about them when we're not. And then 5 out of the 6 are NCI Comprehensive Cancer Centers, and then 5 have their own CTSA awards. So all 5 have Clinical Translational Science Awards. And now what we have is this concept called UC Health, because 2 years ago, we made this decision, it's a public, this is the news that we put out, that the entire University of California will build a single accountable care organization someday. Okay, a single ACO. We call that UC Health. Now, this is aspirational. 10 years from now, we will hopefully have a single ACO, okay? So that doesn't mean UCSF's ACOs are going away or UCLA's, but at some certain point, when a large company, let's say, wants to contract for healthcare for their employees, from prevention to complex care, they can go to one entity and make that kind of arrangement, right? That would be UC Health. Now, it's amazing that this is a panel, and this is going to be a discussion on data integration. Now, our campuses have been sharing data for a long time. We've been using something called I2B2, great open source software, for now 9 years. Okay, we've had that up and running for a long time, one of the first. But we've only been able to count patient data. The academics, for a long time across the enterprise, wanted to share data and put it all in one place. But you know there's a national narrative out there that it is very hard to harmonize electronic medical record data, right? I see a lot of nods here. Let me tell you, it is so much easier to do it when you have a business reason to do it, okay? Beyond just the academic saying, I want to write better papers and grants, we now have a business reason to do it. Because all of a sudden, when you've decided to make a single ACO, you now have to compare the care, right? UCSF takes care of transplant patients this way, UCLA does it that way. That's kind of weird. Or UC San Diego screening for cancer this way, we're not doing it that way, we're kind of weird, right? So you got to start to put all that care in one place and compare and look for practice variation. And you'd be amazed now how easy it is to put all that data in one place when there's a business reason to do it. And the second point is that we don't compete with each other for patients, right? We're a large enough state and we're spread out enough that we do not have to go head to head to try to find patients. So for example, this would never happen in Boston, where even in partners, for example, Brigham and Mass General still have to compete for patients, right? We just don't, except for one thin avenue in Orange County where Irvine and LA kind of abut, there's no real fight among any of us. So what do we have? We have a single database now with all patient care data. I wouldn't be an IT guy if I didn't know how to make boxes point to boxes, so here's the one slide that does that. Here's UCSF, UCLA, Davis, Irvine, Riverside, and San Diego, all in one UC Health data warehouse. Now, Riverside is tiny. They're our newest medical school. They got a couple thousand patients. The rest of these are enormous, as you'll see in the numbers for a second here, how many millions we have here. And all that clinical data goes in one place. At one point, it's slightly easier now because we're all on Epic. It wasn't always the case. Irvine just moved to Epic, but now we're all on Epic. We have different instances, but we have like a handful, a little bit more than a handful number of instances, not thousands of instances. Now, first point I want to make is everything I'm going to show you, except for the next slide, everything I'm going to show you is how that benefits scientists, how it benefits the operational folks. But I want to put in one slide to show how this benefits patients. So actually, some of you might not know that you can actually now, from major academic medical centers, patients can now download their own data through a federal standard called FHIR, FHIR. And in fact, the easiest way to see that is with the Apple Health app. Many of you, I'm guessing, have iPhones. If you go to this really interesting app called Health, if you've gone there before, it used to count your steps and stuff like that, which is bordering on useless. You can tap on health data and then health records, and it does a geolocation. Then if your hospital system tends to be near you, you tap, you log in with your usual portal credentials, and just zoops all the data into the iPhone now. And I'm proud to say now the entire University of California is on that now. So if you get your care across multiple UCs, actually you get a single timeline view of all the lab tests, all the procedures, all of that in one place here. By the way, if you don't know that's already done, you should check this out because patients already know this. Okay, so major health systems are now giving that raw data to patients right now, okay? You don't have to keep fighting for it or saying we should do it. We've done it now. That's there. And by the way, we have a whopping zero, patient-facing prevention apps using data like this, right? Not general data like what should I eat or where should I go to what restaurants or things like that, what's my weight. But given all this health data now, what should I do next? There's a whopping zero apps right now. I'm a big believer that these are going to take off. Patient-facing decision support tools, given actual data from their own medical records now, right? I think that's going to be a big thing for the future. All right, so that's for patients. Now let's switch to what do we do with all this data, right? All right, so we have an incredible view of the entire medical system. So I said UCSF, UCLA, Irvine, Davis, San Diego, Riverside. The number we love to tout is 15 million patients, right? So we have some record data on 15 million patients going back 15 years. We love that number because that's 5% of the US population. 5% of the entire US population has received some care in the University of California. It's a stunning number if you think about it. Now, that goes back 15 years. If we count from the modern era, when we deployed EPIC, and I hate to put EPIC and modern in the same sentence, but you know what I mean, that we deployed EPIC in January of 2012 at UCLA and UCSF. Those are the two big gorillas of the system. So starting from 2012 forward, we have more than 5 million patients, 5 to 6 million patients. And of course, this number changes every week. Now, all that data is in one central data warehouse. We're using a data model called OMOP. Importantly, it's not EPIC. OMOP is so old, it's new again. It came out of Columbia University Medical School, and the FDA was part of the Sentinel project. It's a vendor-neutral way to save patient data, actually. So we're building, there's a lot of open source code around OMOP and tools. We borrow some, we give some back. So we love using OMOP now because it's vendor-neutral. 5.3 million patients with modern data, and just to give you an idea what that means, 125 million encounters. So remember in EPIC, they call every phone call an encounter, right? Just imagine what you could do with just teaching an AI on every phone call, right? Because they're all documented now. I don't know, millions of phone calls. Imagine if you just took the phone call data out of EPIC and just got an AI learning what to do about phone calls. Nearly 500 million procedures, more than 500 million medications ordered. I'll show you those in a moment. 627 million diagnosis codes, and 1.3 billion lab tests and vital signs. We have state regulatory data, integrated pathology, radiology, text elements, and conveniently, we also the University of California, Davis happens to run the death index for the state of California, right? Someone has to keep track of who dies for Social Security and all that. UC also has that contract, so we actually have that integrated as well. So if anyone dies in the state of California, even if they're not our patient, we can tell if they're dying. Or we can tell when they're dead, actually, which is the ultimate thing you're trying to prevent, I suppose, in this meeting. We have self-funded plans, which I'll talk about in a moment. So we have some claims data, harmonizing elements, and we've made some dashboards. So first thing I want to just convince you, I want to make sure you get is that this is not claims data. Everyone's been using claims data for 20 years. This is raw EHR data, right? This is the actual electronic health record data in one place. We have everything from Tylenol to CAR T cells in EPIC now, right? CAR T cells approved. Docs are ordering it. If you want to know how the first, 100 patients are doing CAR T cells, it's in EPIC now, right? We've ordered everything in EPIC. That is the legal record now for every patient here. This is just proof that it works. Geocoding of all the 4 to 5 million patients in this part of the country. UCSF, UC Davis, UCLA, UC Irvine, UC San Diego. Riverside is in red. There's like one dot there. We love them, but there's only a couple thousand patients there. Of course, age, race, ethnicity, and gender. And of course, to make this plot, you realize this is identifiable data, right? We're doing this for operational use, right? We've got quality improvement. We've got a lot of things to improve in terms of quality. So of course we can geocode them. Of course we can get community health markers. All those things are kind of easy. Here's proof that it's beyond claims data. I picked one blood test randomly, LDL, lipid panel. Here are 2.2 million LDL numbers. So just to be really obvious, if you're a claims data person, you'll know that we ordered or paid for an LDL. You'll never know what the answer was, right? But with the EHR data, you have all the results of the test, not just the fact that you bought it. Now, look, I'm technically a pediatrician. I never really ordered this test very much, but I'm told that having this number under 200 is a good thing. Lucky for us, there are 1 million of them under 200. Sadly, there are 1 million of them above 200. So we should make sure these folks are on the right therapies. And now we can make sure they're on the right therapies because this is with all the med data, all the notes, everything in one place here. Now, we're using this a lot to deliver proper care, including proper prevention. Just to give you one example of a dashboard, look, I'm an academic. I write papers and grants. I got NIH funding. But it's amazing how much the world changes when you make this relevant for a health system. Right? When real dollars are on the line, it's kind of incredible and impressive. This is just a screenshot from what UC Irvine has been using for the past year or two. And so we're in California. We're a Medicaid waiver state. We have something called Medi-Cal. The money goes to Sacramento and then portions it out. We got to report quality measures back to Sacramento for quality-based incentives. So for example, colorectal cancer screening here, the state wants us to be at 57.62%. We're at 57.95%. So that bar is in blue. That's a good bar. Hemoglobin A1Cs are too high. The state wants us to be at 84.6. We're only at 73.79, so it's orange, and that's a worrisome bar. And each worrisome bar here is $1/3 So for those of you who are really academics, each orange bar is an R01, right? So R01, 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 R01. R01's all the way down, right? So all of a sudden, it gets really important to fix these problems, right? To make sure at least the quality we're supposed to be delivering is being delivered. Now, a lot of people can do dashboards. That's great. What's neat about this is that when you click on a dashboard, you literally see who is coming in tomorrow, right? Who's coming for a mammography at 8 a.m. tomorrow, or 9 o'clock. So you see UC Irvine's print sheets, UCLA, UCSF. You literally print these out. Here's a patient coming for Adult Infusion Center, Mission Bay, 3rd floor. They're missing one measure. The person coming at 12:30 is missing 2 measures, 4:50, 3 measures. Somebody go there and figure out what's going on. Why have we missed 3 measures on this patient? Figure it out, fix it, and document it Epic today, right? We just got the print sheets one by one. This is how you fix a problem one by one. So everyone can do dashboards. We know who's coming in tomorrow, and we can fix this in real time in that way. So this goes on, and we got a lot of quality measuring that way. The drug data is another whole element of where things are going next with this kind of data. And I could spend 6 hours just talking about the drug data here. Now, this is a blurry slide on purpose because I'm not really going to show you the names, but the top 10 drugs across the University of California health system, right? So it's UCSF, UCLA, UC San Diego, Davis, and Irvine here. Again, Riverside's tiny. Each box here is a different drug. And just to calibrate you here, this entire rectangle is $1.5 billion. So I'm showing you $1.5 billion of drug charges on one slide here, just the top 10 on each campus. Now, as you'd guess, most of these drugs are monoclonal antibodies, right? Biologics. Of course, the United States spends a lot of money on biologics. So then why, tell me, aren't they the same monoclonal antibodies? Why, for example, in areas like TNF-alpha, UCLA is using this one and UCSF is using that one? Explain to me why we can't agree on one way to do this. Somebody should do the comparative effectiveness study on this. That's what we're going to do now. For any of these complex areas, whether it's simple prevention to complex CAR T cells, we can start to do the comparative effectiveness that no one else seems to want to do in the United States. Now, I love PCORI. I love that they've been running for 10 years. I learned recently, I had no idea, that they're not allowed to look at the cost of a drug, right? By federal law. PCORI was prevented to look at the cost of a drug. We have no such prohibition at UC, and we don't need a grant to do this. It's the right thing to do. You're going to see a lot of comparative effectiveness studies coming from the University of California like this. Billions of dollars on the line here. But of course, what we're trying to do is to not just look backwards, it's to look future and look at what's coming up next. And what we're doing is creating an enterprise really to set all this data up. There's a de-identified version, limited data set version, and fully identified version for the academics in the entire University of California. It'll be a killer reason to come to work at UC. That's what we're trying to build here. Really enabling University of California researchers to go beyond, enabling patients to go beyond with machine learning and a safe, respectful, fair, and equitable way to actually change the practice of medicine. I'm just showing you the screenshot of a paper we had recently out where we can now start to predict, for example, if a patient gets admitted, are they going to pass away? Are they going to die during the admission? If they get discharged, are they going to come back? The 30-day readmission problem, we can start to use deep learning. Some are in partnerships with companies like Google and others that we got to work in a very safe, controlled, regulated way with them. Others are going to be ones that we're going to do ourselves. But the idea is now to start to predict the future, what's happening next for patients. Isn't that the point? That is an important point of prevention, is to know what's coming and then try to avoid it or to delay it here. So for example, one paper we just had out a couple weeks ago is on predicting the future state for a patient with rheumatoid arthritis, right? So to me, it's also kind of puzzling. Prevention, again, I'm an outsider here, right? I'm not a prevention researcher at all. But to me, a lot of prevention seems to be about avoiding or trying to avoid having a disease. I think an important component of prevention of the future is to prevent worsening of a disease. Because a lot of people end up getting a condition. I think preventing the worsening should also be considered prevention someday. Here we can predict 90 days from now, if a patient comes in right now with rheumatoid arthritis, are they going to have a flare? Are things going to get worse? And if you just dial in the different drugs that we can use, then we can start to predict what happens next. And you can see ROC curves. Now, this is an example of how we're trying to do this the right way. We train all of this data at UCSF, our hospitals, but we also validate it at San Francisco General Hospital, a very different hospital than UCSF. Different patient populations, different race, ethnicity, socioeconomic status, different use of the drugs. And the model's got to work in both, or we're not doing this right. And we're not doing this fairly, okay? Because I think that's the next bar. Not just showing that the computers can do this, but actually can do this in a fair way. All this is leading to what we call a new deep learning healthcare system. Not just a learning healthcare system, but the computers can start to ask, before the experts say we should look at this, right? The computers notice that there's a problem. And this just came out as a paper in a couple months ago as well. So I'm at the end of my time. Let me just end with the last minute what I want to do with this kind of data. I'm trying to build maps of death and disease in California, maps of death and disease. Some of you use maps, right? Let's say Google Maps. Maybe some of you use Waze. My car makes me use Apple Maps. It's getting better, believe me. But the concept of maps might take you to pleasant destinations. I'm trying to figure out if you're healthy or if you're sick in California, how do you get diseases and die? And we're going to try to learn the maps from the data. So there's this is by Hannah and Jay. There's a preprint in bioRxiv now. Here's an example of a map we've learned from California data. Patients showing up with alcoholism. A year after that, they have liver disease and cirrhosis. A year after that, they have liver abscess. So each arrow is a year. Or you can come straight down this way. And the squares mean you die of those conditions, right? So it's really hard to die of alcoholism, but actually you can die of liver disease or cirrhosis or liver abscess. Does that make sense? All right, this is a more complicated map. Here we've learned patients have heart attacks. Everyone knows what a heart attack is. You can die right away, or you end up with heart failure a year later, right? The heart is too weak as a pump. The fluid backs up into the lung. You have lung disease here in orange. And a year after that, we have sepsis. Sepsis. Now, that's kind of interesting to me, right? We're learning from the data sepsis. Look, like I said, I'm a pediatrician. I didn't really take care of a bunch of patients with heart attacks, but I always thought that when you had a heart attack, it was the heart that killed you in the end. I'm amazed how many patients are dying of the sepsis in the end, right? And are we really even screening for sepsis at home? Are we super concerned in a post-MI patient when they have a fever at home? Not really sure that we're super concerned about that. And it's important because if you don't take the northern route, you can take the southern route, kill your kidneys, and end up with sepsis a year earlier, right? So you got two ways to get the sepsis, right? You see that? So these are maps. And so the whole concept of maps is you know where you are, you know where you could go next. And if it's not a place you want to go to, you can start to avoid, right? I guess that you could call prevention, right? But you got to know where you are, and the data tells you that we can see again and again patients go here next. Now, I love maps like this. I love Google Maps. I love Apple Maps. But there's still one thing, those maps, those mapping softwares like Google Maps, there's still one thing Google Maps can't do. Google Maps still can't show you where are all the cars on the map. I know it shows you the traffic, red, yellow, green. I know that. But there's no way for Google Maps to show you where all the little itty-bitty cars are on the map. But when we open our new building in Mission Bay at UCSF, we're going to have a wall of monitors in a conference room and not just show the maps, we're going to show literally where are all the patients on the map. This is a real prototype with real California data. This is literally how Californians move from disease to disease to disease to death as they get older. A whole bunch of them are about to get sepsis and die in a moment. There they go. It's okay, everyone chuckles there. And now we can start to predict what's going to happen in the next 90 days, what's going to happen in the next year, and what are we going to do about it? And that, to me, is going to be the new definition of an accountable care organization, one that knows how to account for the care of each of its 15 million patients. And that is what I'm proud of building at the University of California. I can't do this with a whole large list of collaborators across the University of California, Stanford, and NIH. I thank UCSF and Priscilla Chan-Mark-Zuckerberg for endowment support. My lab is funded by 20 NIH grants across these 11 institutes of NIH. The ones on the left give me more money. The ones on the right give me less money, but I still love them. A lot of other disease-specific foundations. I thank my admin at Tech Stuff and never get a grant or paper out the door. And all my friends, family, and mentors that have been taking care of me for my 20-year career so far. So thank you very much. We have time for a couple questions, right? All right, we have time for a couple questions. Of course, the main discussion is going to be across the hall there. Put your hand up. We're going to try to run a microphone to you, but if we don't reach you fast enough, I'll repeat the questions here. Questions, comments, issues, complaints. Right there in front.
Hi, thank you so much for the talk. It was very illuminating. I'm curious to learn more about what types of behavioral health data points you're collecting.
Yeah, so behavioral health is kind of curious, and also, so behavioral health data in particular is different in every state, right? There's state regulations on the agglomeration of that kind of data. So, so for example, by default, we can't move in mental health data of certain types. Just like certain tests, like HIV tests and things, we can't move in automatically. So we got to follow state regulations and things like that. That being said, the primary care notes, so even without the primary care notes actually mention a lot about the mental health. We can certainly see what medications are on, things like that. So it's not going to be a generalizable answer here. In California, we are a little bit limited to move inpatient mental health. Outpatient, we can get a lot of that way. Out of the 5 or 6 million recent patients we've seen, about 1 million, by the way, are primary care. So we get a lot of that there. We also can look at the notes. So for example, we know exactly how many notes mention homelessness, how many notes mention hunger. Very curious, the sentences that mention those. So remember, we also have the notes here. Smoking we have actually in structured form. Actually, it's not even in the notes. So, because we have to report that to the state, so we go extra crazy trying to find smoking. But UCSF might have it in 5 places, UC San Diego has it in 3 places. That's all harmonized, and I can go into the technical details there. It's not actually impossible to do.
Thank you.
There's a question in the front here, if we still have time.
Hi, Lillian Gelberg from UCLA.
UCLA, our
Loved your
sibling.
presentation.
Thank you.
We're trying to do, we just got funded to do prevention through EPIC,
That's
through
great.
EHR.
Yeah.
It's tough though, because you can't modify EPIC.
Yeah, okay, so you can't modify
There's-
EPIC. So it's a great point. So the important point is that this is all read-only out of EPIC. To put stuff back into EPIC is pretty hard, okay? So there's got to be a specific kind of transaction where you can order things and things go back. EPIC is very constrained. There is a little bit easier way to put up little panels, right? Web-based panels or tabs that you could provide some decision support. Not trivial at all, okay? These are APIs or application programming interfaces. So, showing pretty pictures like this is easy. Getting the docs to change is hard. Getting them to change through something in EPIC is even harder. Finding those consultants or programmers is expensive. Totally get it. I make everything seem easy here. But to actually change that practice is pretty hard.
So I'll talk to you after. I
Oh,
would
of
love to
course.
partner with you.
Surely. We are already partnering. All right. Thank you very much. I look forward to talking more in the discussion room next time.